So, so I'd like to welcome everybody tonight to our webinar on advances in the treatment of aortic dissection. My name is Eileen Michelli, and I am the Chief Program Officer for the Marfan Foundation. And the GenTAC Alliance, which is presenting tonight's webinar, is powered by the Marfan Foundation. So we're one big happy family here, and we're glad to bring you all this great information. Thank you to everybody who pre-submitted questions. Many will be answered during the presentation, and we will also address as many as we can during the Q&A session tonight. So please put any questions that you have in the Q&A box, not the chat box. If you can, refrain from putting lots of personal information because we'll never get to your question then. So keep it short, and we will do the best that we can to answer as many questions as we can. Helene, who you see there, will be in the chat box and provide you with useful links to tonight's topics. So to get us started, what I'm going to do is I'm going to first introduce you to Dr. Alan Braverman, who we just learned looks a little bit like Harrison Ford, who is also from Missouri. Dr. Braverman is the Alumni Endowed Professor in Cardiovascular Diseases and Professor of Medicine at Washington University School of Medicine. He's also the Director of the Marfan Syndrome and Aortopathy Clinic. He's a member of the Marfan Foundation's Professional Advisory Board and our Board of Directors, and he chairs the GenTAC Alliance's working group on patients, families, and clinicians' education. So Alan, over to you. Say a few words.
Thanks, Eileen, and thank you everyone for joining us. It's going to be a wonderful meeting tonight, and I know we're all going to learn a lot from our two experts. Thank you again to the GenTAC Alliance, which is an organization that was initially funded by the NIH and now is supported by the Marfan Foundation. It's a group of experts, clinicians, patients, families, and others who have interest in genetically triggered aortic disease. So thank you very much for your sponsorship of tonight's webinar. I have the privilege of introducing two great colleagues and close friends. And I want to thank especially Pooja Katra, who's in the OR right now and unable to provide her talk. She was going to give this lecture. So thank you so much to Marc Moon, who's stepped up to the plate at the last minute to provide the lecture. So I'll start with introducing Marc Moon. Dr. Moon is a professor of surgery and cardiac surgery and chief of cardiac surgery at Washington University in St. Louis and Barnes-Jewish Hospital. He's the current, maybe the immediately past president of the American Association of Thoracic Surgeons, and he's a world leader in aortic surgery and a trusted colleague. And Dr. Moon's going to talk about some of the surgical aspects of aortic dissection and proximal aortic disease. So thank you very much, Dr. Moon, for joining us, and we're looking forward to learning from you. And I also have the privilege of introducing Dr. Westley Ohman. Dr. Ohman's assistant professor of vascular surgery, and he's the assistant program director at WashU in the vascular surgery division. And he's been very active in the genetic aortic world at our university, tackling the most difficult cases in vascular surgery, both endovascular and open surgery. And he's a rising star in this field and a trusted colleague, and I'm really looking forward to his talk as well. So without further ado, I'll exit and welcome my colleagues and friends to provide the lectures.
All right, so I'm going to stop sharing and give this over to Dr. Moon here.
Great. All right, I'll share my screen.
Okay, yeah.
Let's see. Let's go with that. Can you see my slide?
Perfect, thank you.
Okay, great. Well, I was asked to talk about surgical management of acute type A aortic dissection, which is, you know, a critical component of treating patients with connective tissue disorder. And my disclosures are I'm on the advisory board for Medtronic and a consultant for Edwards, but I'm not going to talk about any specific products, so that won't be an issue. What I'm going to talk about and try to summarize in the next 15 minutes, review some of the anatomy so we all are talking in the same language to some degree, the classification systems of dissections, and discuss how patients present with acute dissection, what the workup is, and some of the surgical management options. So acute type A aortic dissections are the most common catastrophic event involving the aorta. In the United States, it's about 5 to 20 cases per million population per year. And that's actually more common than even a ruptured abdominal aortic aneurysm, which takes a lot of lives each year as well. The mortality, though, is very high. It's documented to be 1% every hour initially, 30% by 24 hours, 50% by 72 hours, and 90% by 3 months. So a very, very mortal complication and process. About 50% of aortic dissections, though, are misdiagnosed initially. You have to have a high index of clinical suspicion. But remembering, though, that less than 1% of patients who present with chest or back pain in the emergency room actually have a dissection. But it has to be in the back of your mind because it's one of the most morbid. 10% of U.S. hospitals perform more than 10 dissection repairs every year. That's not very many. And the average number of repairs at most hospitals is only 3. So it's a very rare occurrence at sort of the average hospital down the street, which takes care of a lot of very, very important problems. But this is kind of a disease that really benefits from some focused treatment therapies because the operative mortality at a low volume center is 28% compared to a high volume center, which is 16.4%. There's even better results if it's an aortic program that's focused on the therapies, which is why we like to think of moving towards regionalization of care of comprehensive aortic disease so that timely care for optimal patient outcomes can be achieved. Let's look at some anatomy of the aorta. It starts, essentially, this is a drawing I draw in the clinic almost 2 or 3 or 5 times a week in clinic. I only have clinic 1 day a week, so I don't draw it too often. But what this is your heart is below the aorta, and then the aorta begins, and then you have the sinotubular junction, which is essentially the portion that starts the aorta. That's where number 2 is. Number 3 is the mid-ascending aorta. Number 4 begins the aortic arch where it curves. And those are the 3 blood vessels that go up to your head and your arms. The innominate artery, which goes to the right side of your brain and your right arm. The carotid artery, which goes to the left side of your brain. And the subclavian artery, which goes to your left arm. And then the descending aorta comes down, which Dr. Ohman is going to talk about. So acute aortic syndromes involve various portions of the aortic wall. There's essentially 3 major sections of the wall: the adventitia, which is on the outside, the media, which is on the middle, and the intima, which is on the inside. And you see the vasovasorum, that's blood vessels that are in the adventitia that feed the aortic wall itself and give it its nutrients. Let's look at an aortic dissection. An aortic dissection, and you can see in number 1, you get an entry tear. There's a tear that occurs in the wall of the aorta. And then what happens is blood shoots into that tear and creates what you can see in number 2 is a false lumen. The FL is false lumen. And that's where the wall splits. The intima and adventitia split apart as the media fills with blood. And then eventually you can see an exit point at the top where the blood exits out and the false lumen stops. In the there's a couple other things that come up. Intramural hematoma, that's essentially a dissection that doesn't really have an identifiable entry or exit. And some people theorize that's from bleeding from the vasovasorum I mentioned earlier. The penetrating aortic ulcer is more a process that occurs most often in the descending aorta, where there's an ulceration and then ultimately it erodes through and creates the false lumen. The classification of dissections, there's 2 classic classifications. DePeggy, who was a surgeon down in Houston for many, many years, who actually had a dissection ultimately when he was in his late 80s that was repaired successfully. But it's a type 1, which starts in the ascending aorta and goes all the way around the descending. Type 2 starts in the ascending aorta and is localized there. And a type 3 starts in the descending aorta. The Stanford classification was more of a surgical classification system. The type A means anything that involves the ascending aorta, meaning this patient needs emergency surgery if there's no other reason not to. And the type B is a descending dissection that may not need emergency surgery. The clinical presentation is abrupt in onset. I always ask the patient, when did your pain start? And they will say 4:30 when I got done watching television and went up to go get a bag of potato chips. They will be able to tell you exactly the minute it started. It's the severe or worst pain they ever experienced. Chest pain or back pain is most common. Patients are oftentimes hypertensive, but that doesn't rule it out. If patients don't have a high blood pressure, they can still have a dissection. And oftentimes, if they have a low blood pressure, that means it's a much more severe situation. There's deficits in the pulse because those false lumen can tear off side branches, and so maybe you can't feel a pulse in your right wrist, and that's because that innominate artery has been torn and there's limited blood flow now to your arm. Widening on a chest x-ray is something we see, but the diagnosis is challenging and it's missed on the initial examination in emergency rooms in up to 40% of patients. If a patient presents with only abdominal pain, that's not very common, but that's most often a type B, and it's also quite morbid as it's associated with a much higher mortality rate. Painless, presenting with syncope or heart failure or a stroke because one of the side branches of the aorta has been compromised is also bad. When it involves the mesenteric is the blood vessels to the belly, and that is very much a very poor prognosis sign. And we're developing new ways to treat that better than just doing emergency open surgery, and we'll talk about that. Dissections most often occur in the winter, more often than the summer, probably because of vasoconstriction, clamping down of the arteries that can cause higher blood pressure. Risk factors include the classic patients, a male age 50 to 70 who has hypertension, but that's also the typical patient that has a myocardial infarction or a heart attack. If you're greater than 40, it's generally because of atherosclerosis, or in women, they can have aortitis, which is an inflammatory process of the aorta. In patients who are less than 40 years old, it's usually a collagen vascular disease, connective tissue disorder. And patients who have a bicuspid or two-part aortic valve are also more commonly prone to dissection. We don't do natural history studies like this anymore because we can treat these patients. But this was a study from the late 50s looking at what happened to patients who had dissections before there was any treatment. And it was morbid. By 48 hours, 50% of patients had died, and by a week, 70% of patients had died. The cause of death in an untreated type A dissection is usually rupture of the aorta with tamponade, which means blood surrounding the heart and squishing it. And that's something we can prevent with surgery and deal with immediately. There's also other areas that can rupture, and also blockage of branches that are important. If you look at what predicts a problem, and if you have an aneurysm, your aorta is getting bigger and bigger and bigger. At what point does it become a problem? Because it's like your aorta is like a balloon. If it's blown up just a little bit, it's not going to pop. But if it gets really big, then it can be a problem and be at risk. And so the Alftieri, he's a surgeon at Yale who's been studying this for many, many years and has followed many, many patients, found that there's a hinge point at 5.25 centimeters where the risk goes up. And then there's another hinge point at 5.75 centimeters where the risk goes up even higher. So that's why we sort of recommend elective surgery in patients who are otherwise good candidates for surgery when their aortas reach these sizes. Now, this is a pretty complicated graph looking at comparing the aortic size to your height. But if you look at 1.8, which is about a 6-foot tall person, you can see that if their aorta, and the blue is low risk, red moderate, green high, yellow severe. If a 6-foot tall person has a 6-centimeter aorta, they're in the high risk area. And if it gets up to 7.5 centimeters, they're in the very severe high risk area. So it's kind of based on your height, your weight, and your aortic size. So when do we treat an acute dissection? Well, any patient who's deemed survivable. And so it used to be that, oh, if you're over 80, you don't get treated. But that's just not true anymore. We have plenty of patients that show up in their 80s who have had a dissection and we're able to repair those successfully. If a patient presents with a stroke, that can reverse when you fix the dissection. Intramural hematomas we talked about, and atherosclerotic ulcers we talked about, both are indications for surgery, but may not be indications for surgery immediately. But a type A dissection with a tear is generally an immediate trip to the operating room. The goals of surgery are to fix the immediate problem, get rid of tamponade, get rid of hemorrhage, bleeding. get distal flow going back into the true lumen. We talked about the false lumen. We don't want blood going in the false lumen. We want to get as much going in the true lumen, which is where the blood vessels generally come from. We want a correct compromise if your coronary blood vessels or your blood vessels to your head have a flap in them and aren't getting good flow. We want to make sure your aortic valve, which is at the bottom of the aorta, is competent, because the dissection can spread the aorta apart and make that valve leak. Also, we want to get rid of that tear if we can, because that will help our long-term survival. And ideally, we want to eliminate flow in the false lumen, but with a type A dissection repair, that's generally not an ultimate result. So if the IRAD database is a database all over the world that puts all their data into one spot and looks at results, with medical therapy of a type A dissection, the mortality is 58%. Now, that's improved over what we saw in the study from 1958, but that's because we've got much better medical therapy now and we understand the disease better. But that's not the way to go. Surgery overall has a 26% mortality, but again, I said if it's at an aortic center, it can be much less as we get to these patients earlier and they've got much better therapy options. The American Association for Thoracic Surgery just came out with new guidelines on how to treat this. And the idea behind putting together these guidelines were so that the centers who do 3 cases a year or less than 10 cases a year kind of know the best strategies that have been developed by the centers that do many of these each year. So we need to talk about cannulation. That's how we put somebody on the heart-lung machine, whether we do in the vessel near your head or a vessel in your leg. These are all important things to consider. We need to protect your brain because we have to cool the aortic dissection down very much in order to do the repair. We want to maintain the right temperatures to protect the kidneys and the liver. And then we have to be able to fix the aortic valve if it's leaking and get it back to a non-leaking state. And also, how much of the aorta do we take out? Do we take out just the portion that's torn, or part all the way up to the arch? And these are all things that we have to consider with surgery. So here, let's look at the options for repair. Supracoronary commissure replacement. That's an ascending aortic replacement is letter A. And that's just a classic repair. We repair the portion of the aorta that's going to be the reason for death. And that's because of rupture or tear into a coronary artery. A hemiarch replacement is a more elegant operation that eliminates a great portion of that ascending aorta and is better for long-term results. A total arch replacement, we don't usually do that operation because it's much more extensive in an emergency situation, maybe much more morbid. But what we're leaning towards and developing safe ways to do is what's called a frozen elephant trunk, where we replace the hemiarch and put some sort of stent device, and these are all under experimental studies at this point, but some sort of stent device down that will restructure the descending aorta. So hopefully that won't be a problem down the road. Valve sparing aortic replacement is also a way to take care of the valve and the base of the aorta, especially in patients who have Marfan syndrome and associated disorders, in that we can preserve your valve and keep it functioning so you don't have to have a mechanical or a biologic valve. At Washington University, we just presented our series at the last surgical meeting of 177 of these patients who had valve sparing procedures. Very young patients, average age of 43. They often had hypertension, but most often they had a connective tissue issue, Marfan, loeys-dietz, or other connective tissue issues. Most of these were elective. We did do some emergently, and some of these are the specifics of the surgery. But the complications are actually quite low for such a complex operation. Atrial fibrillation is something that happens to patients always after heart surgery, or very commonly. But if you look at the permanent stroke and 30-day mortality, if you're doing this operation on a frequent basis and you are experienced with it, the results can be quite good. If you look at late survival, 97% at 5 years, 91% at 10 years, and this includes patients all over the spectrum of age. So this is quite good. And freedom from having to re-intervene on the valve is also quite significantly good. The valve, with the repair, will last a long time. These are a couple most important things. I've got a good friend, Joe Bavaria, who works at the University of Pennsylvania. And when we publish these data, he told me he keeps these two graphs on the wall of his postdoc clinic so he can show them to his patients, because this is the most important thing for the long term. Blood pressure control. If your blood pressure is less than 120 in late follow-up, the chances of needing a reoperation are quite low. If your blood pressure is greater than 140 in the long term, the chances of needing a reoperation by 10 or 15 years are almost 70%. So this is very important. And also beta blockers. If you use a beta blocker, the chances of reoperation are pretty low. If you don't use a beta blocker, they're very high. So these are two important things for patients who've had a dissection. And we've actually started to use this in elective patients before dissections as well as therapeutic approach. And the risk of late reoperation, like they talk about the ascending replacement versus this extended hemiarch, very important, because the extended hemiarch patients almost never need a reoperation on the front of their heart. So early diagnosis and institution of definitive therapy is the key. Surgical treatment doesn't cure the generalized disease. We always have to continue to follow these patients with strict blood pressure control. Negative inotropic therapy, it's called. That's the beta blockers. Even if you have normal blood pressure, a beta blocker is helpful. Beta blockers save lives. And serial imaging surveillance is done indefinitely. Our initial goal when treating a patient is to get the patient out of the operating room and out of the hospital in one piece. And for experienced comprehensive aortic centers, extended resections or complex valve sparing operations may be an option. And these are things that we're trying to explore and expanding our therapeutic regimens. So if there's any questions, we'll answer them here now today, but if anything else comes up, feel free to call my office or email me. I'll answer any email. It may take a day or two to get back, but I'll promise I'll get back to you. So thank you very much.
All right, let me go ahead and hopefully share the correct screen. Is everyone seeing the main presentation?
You're good, thank you.
Perfect. So my name is Westley Ohman, and it's honestly an honor to be paired up with Dr. Moon, who taught me so much about what I'm going to be talking about in terms of management of type B aortic dissections in patients with genetically triggered aortopathies. I have no financial disclosures, although I am a co-PI for multiple trials looking at aortic endografting, and I will be talking about that in a general sense. I want to expand upon what Dr. Moon talked about in terms of some definitions as we move forward, or that you may hear in the clinical setting, one of which is the time course, and that's what we talk about. Anything within the first 2 weeks from that event, that sudden onset pain that Dr. Moon described, is described as acute. And then the reason we think that's important is that it's a fresh dissection. The intimal flap is incredibly friable and thin. You can see on the intravascular ultrasound picture just how mobile it is with each beat of the heart. And it doesn't take much from a force sewing a needle, grabbing it with a pair of forceps to really tear that. At the other end of the spectrum, anything greater than 3 months is considered chronic, and that the mobility of the flap is greatly decreased, and it's really started to scar down, and it behaves much differently. And then subacute is kind of in that 14 to 90 day window. Most importantly, when we talk about type B, the question is it complicated? Meaning, are there downstream consequences? The most feared complication is, of course, rupture, because that's the one that carries the highest mortality associated with the disease process. There could be poor perfusion to any area of the body downstream. Dr. Moon mentioned the right upper extremity for type A's. It can extend into the intestines, to the liver, to the kidneys, down to one leg. It can be associated with intractable pain. So despite significant anti-impulse control or using a high dose of beta blockers to the IV, you can still have intractable pain. And we think those patients are at a higher risk of progressing towards rupture in a more significant event. Here's a slide, a still shot of that previous image showing that dissection flap extending out into one of the intestinal vessels. And that's really the challenge for some of these dissections, is how do we best manage them? But ultimately, what does all of this mean for you, for patients who do have a diagnosis or a suggestion of a genetically triggered aortopathy? There are some risk factors that we're starting to peel out from these larger institutions and databases in terms of what is your risk of progressing to a type B dissection, regardless of previous ascending repair or based on previous dilatations of the aorta. And so if you've had previous aortic surgery, whether it's a valve sparing root, as Dr. Moon talked about, or sometimes patients present with an enlarged abdominal aortic aneurysm that needs to be repaired, your risk of developing a type B dissection is roughly twice as it would be compared to someone who doesn't have any sort of reconstruction of their aorta. And particularly for the root, we think it has to do with the way the pressure is transmitted with each beat of the heart. I like to tell my trainees that the aorta really plays catch with the blood ejected from the heart rather than kind of this smooth flow. There's this expansive effect. And when we take away that expansive nature of the ascending, that increased pressure gets transmitted to the beginning of that candy cane that Dr. Moon showed. And so it changes how the aorta behaves downstream. And if you have a dilated, any segment of the descending aorta above 2.7 centimeters, similarly, you have a roughly twice as increased risk. So our experience here, following Dr. Braverman's clinic of roughly 257 patients, just over 10% have a type B dissection that we are following. And these are de novo type Bs that do not have an extension of a previous type A. You see the roughly evenly split, and then the age of onset when they began is roughly similar between the two genders in kind of the mid to late 30s. And we're starting to wonder, what is it about male versus female or certain genes that predispose some people to having aortic events at an earlier age? We know that on average, patients with loeys-dietz or vascular Ehlers-Danlos can have aortic events at younger ages than Marfan patients with Marfan, excuse me. And so there's this question of the phenotype-genotype interplay. We know that certain gene mutations within the Marfan family are associated with a higher rate of ectopic lentis or skin and skeletal maturations. And these are certain types of mutations that either switch one of the amino acids or the building blocks of the protein so it behaves differently, or it terminates the manufacture of the protein early. But what about cardiovascular manifestations? And so here's a slide showing that we have begun to identify either certain types of mutations or certain regions of the gene that's impacted that leads to aortic changes, whether in the ascending or the descending. And so we're starting to get this really early picture of what patients are at higher risk based on their genetic testing. And so haploinsufficiency is the idea that you really produce essentially no true functioning nature of that protein. And then dominant negative is a different type where you have essentially one functioning and one non-functioning component. And in general, those patients who have a complete kind of knockout or knockdown of the fibrillin protein have higher aortic event rates compared to those who have just a plain dominant negative mutation. However, if they have one that involves a change specifically involving a certain type of building block, or once again, a certain region of the protein, they're also at a higher rate of aortic events. This hasn't made it into guidelines yet, but I think that's one of the more exciting things about this genotype-phenotype interplay is really taking what we know from the genetic testing beyond just, yes, you have loeys-dietz, yes, you have the genetic variant associated with vascular Ehlers-Danlos or Marfan syndrome, and really saying this is what it means for you at different time points. So we're going to treat you differently. We may up-titrate your beta blockade. We may be more aggressive with an angiotensin receptor blocker. And I think that's where we're going to see some of the, actually a lot of the shift in the clinic change over the next several years. What about pregnancy? This is a very common question. And we presume that these females who are pregnant are at a higher risk due to the physiologic changes. The heart has to work harder so that, that baseball is being thrown harder when the aorta plays catch with it. There's a higher rate of cardiac output as well, so there's more blood flowing to support the growing and developing fetus. And type B dissection rates range in the literature anywhere from 1.4 to about 3%. And the one risk factor is a prenatal aortic diameter of greater than 40 millimeters or 4 centimeters is associated with an increased risk of developing a dissection during your pregnancy. When is the risk the highest? Really during the 3rd trimester. And I talked about a lot of the physiologic changes driving some of the risk, and those changes don't immediately stop with delivery. And so the second highest phase of risk is actually in the immediate post-delivery period up to about a month afterwards. And so it's really critical that patients are closely monitored by both a cardiologist as well as someone with an experience in maternal fetal medicine managing patients with a connective tissue disorder. Beta blockade has essentially been a standard therapy, and to Dr. Moon's point, it does save lives. It has been associated with lower birth weights during pregnancy and then subsequent delivery, but it hasn't been shown to have any long-term outcome effects on the child after their exposure. So there's some change in guidelines, and we saw it de-emphasized a little bit in the European Society guidelines in 2018, but I think in the right context and following with experienced cardiologists and maternal fetal medicine specialists, they play an integral role in managing probably one of the highest risk parts of a woman's life with a connective tissue disorder. Medication remains the gold standard. Nothing has changed. That's true for type A, that's true for type B, as well as residual dissections after type A repair. Beta blockade is a mainstay of therapy. There was a lot of excitement about a decade ago about angiotensin receptor blockers in an animal model, and large series really haven't shown that significant effectiveness after human trials, but they still play an important role. Surveillance is mandatory. The rate of growth averages about 2 to 4 millimeters per year after a dissection, and that rate is higher in certain genotypes as well as patients who have less ideal blood pressure control. So when do we make the decision to go to the operating room? If it's an acute malperfusion issue with solely a type B and they're relatively stable, I want to be very clear, the gold standard still remains open surgery for type B dissections in patients who are stable and stable enough to undergo repair. Patients who dilate over time, if you imagine you take that third layer or the third layer of the wall and tear it away, you have 2 layers of strength. And so you're going to dilate over time. Classically, 6 centimeters is the absolute cutoff that we recommend repair, but that's individualized. If there's a sudden rate of growth, if there's patients who desire pregnancy, there's a variety of factors that we take into account both as vascular surgeons, as cardiac surgeons, and as cardiologists in terms of when to recommend going to the operating room. So once that decision's been made, the immediate question is, what is the problem I'm trying to solve at that moment in time? Because there's always going to be downstream effects with a type B dissection. To Dr. Moon's point, it's very, very rare that we solve the entire problem with a single operation. Is it rupture? Is it the poor perfusion to a certain area of the body? Is there pain? And all of that plays into, is this someone who potentially gets an open repair? To Dr. Moon's point, for if you have liver or intestinal ischemia and you have certain markers on your lab preoperatively, that's a sign that you have a poor outcome if you go to the operating room without that corrected. And so there may be a role as we get a more experience with this in terms of trying to fix that endovascularly using balloons or stents in advance of the definitive repair after the acute event is over. And it all comes down to balancing the risk to the patient with the benefit they're going to get from that moment in time. We're not aiming for a home run all the time. We're trying to, once again, get the patient through an operation and through the hospital stay with as little morbidity as possible and set them up for success over the long term. And so I have to be clear. GenTAC has a statement, and this is true for patients who are stable and are undergoing elective repair. Open surgery remains the gold standard. There's a variety of techniques that vary depending upon centers. We happen to use left heart bypass with possible femoral bypass for the ability to better control the proximal anastomosis with our cardiac surgery colleagues. And that allows us to perfuse the lower extremity, the pelvis, the spine, as well as the mesenteric or the intestine and the kidney arteries as we're doing the reconstruction kind of in sequence, once again, trying to lower the overall morbidity and physiologic insult to the patient. However, there are some patients who may be too high risk for open surgery. They may be presenting with in a true emergency where if the bleeding from a rupture is not stopped immediately, they won't tolerate open surgery. And those are the patients that benefit from TEVAR or endovascular repair using a stent graft in very select patients with very experienced teams with very high risk features. And the reason for that is there are a high rate of both acute as well as delayed complications and reinterventions that do require really a multidisciplinary team. And at best, they should be thought of as a bridge to a more definitive therapy. And why is that? So endovascular repair sounds so much better than a big open operation. It's 2 needle pokes in the groin, you're watched in the ICU. But we really have to go back to our original question, what is we're treating at that moment in time? And so for patients without a genetic aortopathy, this has become the initial therapy. There's less physiologic stress around the time of surgery. There's still similar risks of spinal cord ischemia or spinal stroke because the blood supply to the spine comes off regular intervals of the aorta. So if you cover a significant amount or you replace a significant amount surgically, there is some risk of a stroke of the spine. But you have to ask yourself, what is the goal? What is my long-term hope for this patient by placing a stent graft? Is it to reduce mortality? Is it to reduce death due to aortic events in terms of rupture? Is it to induce favorable remodeling to where I don't have to offer subsequent procedures? And so the largest experience we have looking at patients, once again, without genetically triggered aortopathies, with dissections and endovascular repair, really didn't see a benefit out until you got to the 2 to 3 year mark. Granted, they were sustained at 5 years, but for the first 2 years, those patients did just as well as if they were medically treated. And so endovascular repair is not the magic bullet or the panacea that we had all hoped. Most of the experiences in the literature are single study or single center institution reports with a handful, maybe 2 dozen at best. And you can see for patients in both dissections as well as aneurysms, there's a significant amount of reintervention in terms of both open surgery, maybe percutaneous interventions, and there's still some amount of mortality associated with these types of repairs. We are writing up our experience and we do have one of the largest series, but you can see we still have a 6% stroke risk. Compare that to Dr. Moon's previous statement, 3% risk of the paraplegia, that spinal stroke. Endo leaks are where we have either an incomplete or an inadequate repair. And you can see that there's about 40% or so of our patients, and we are a very high volume, very experienced center. A lot of 6% of patients have another procedure within 30 days of their implant. And then even after that 30-day mark, there's 30% or so of patients go on to require another intervention. And there's this idea of this stent graft induced new reentry tear. So even if we tried to cover the tear with a stent graft and redirect flow out of that false lumen and only into the true lumen, the stiffness of the endografts is such that that can tear that very mobile, very friable dissection flap and allow perfusion to re-enter the false lumen. And so we see that in about 1/5 of patients. Shifting to a large database series, looking at national registries here in the US, over 100 patients were identified meeting diagnostic criteria of either Marfan syndrome, vasculitis annulus, or loeys-dietz. And these were done for roughly equal aneurysms, acute and chronic type B dissections. And what they saw was still a fairly significant risk of an endoleak and reintervention downstream. Their overall mortality was 5% at roughly 15 months after follow-up, and 3 of them had retrograde type A dissections requiring emergency cardiac surgery. So it's not the magic bullet, like I said, and it really has to be used judiciously and selectively. I mentioned delayed aortic events are real, and I don't mean within the first 30 days. Here's a patient that we treated here who had her endograft placed elsewhere 8 years ago. She was fortunate. She had remodeled her aorta well at that stented segment, but she presented with an intramural hematoma within that stented segment. And she ended up requiring open conversion because of intractable pain and enlargement at that section. And so it's not a fix even over the long term. You still require long-term follow-up and then open surgery for downstream events and even events within the stented segment. And the way we repair patients who've had a previous stent graft open is we try to incorporate the stent graft as much as we can. We think of it as more as a pledget or something to reinforce the suture line rather than something that's a definitive repair. And so we do end up removing a significant amount of the stent graft when we do our conversions for downstream events, whether it's aneurysmal dilatation or a change in the dissection flap that ends up causing malperfusion. So where are we going in the future, and what, if you take away 4 things from this talk, what should it be? 1, blood pressure control is essential. Both pre and post dissection events, beta blockade does save lives. I think we're going to see the genotype as a risk predictor within certain diagnoses of aortopathy. So not just Marfan behaves one way, loeys-dietz behaves one way, and vascular Ehlers-Danlos behaves one way, but certain mutations within the Marfan family or within the vascular Ehlers-Danlos family behave differently. And so we're going to be more aggressive with X therapy. Endovascular repair is a option in very highly selected patients in emergency or extremis and should not be thought of as a first-line repair. And then long-term surveillance is mandatory. Even if you have great images and great remodeling of the aortic segment, you can still have late aortic events. And so please do not think we pat ourselves on the back after we put an endograft in and it's 30 days or it's 1 year. These are patients that are still aggressively followed and do require late intervention. So as Dr. Moon said, please feel free to email me. This is my office phone number. Call. I'm one of the younger generation, so I am on Twitter. If you want to engage me there, feel free to do so. As Dr. Moon, Dr. Braverman, Eileen, myself can all attest, this is something that we all feel passionate about and want to see improved care across the world for patients with these conditions. So thank you, everyone.
Thank you both so much. That was really, really great. So much information in such a short amount of time. We have lots and lots of questions. So let's start with a question for Dr. Moon. You mentioned the new AATS guidelines. What were the 3 big changes that came out of that?
Well, I think number 1 was the extent of the resection. It used to be, like I said, our number 1 goal is to get the patient out of the operating room safely and move on to the next. But we've started, and one of the questions I saw come through in the chat line is, what about a dissection that is present beyond a repair? And that is actually a very common occurrence. And I think Dr. Ohman and I, in the last 2 weeks, have dealt with 3 patients with this exact same problem. And it's very complex because patients need another surgery through the front and potentially another one through the back. So I think one important thing is the extent of resection. So if we can resect enough aorta that we can prevent sort of that second operation in the front, that's the most important thing. And there are very, very safe ways to do that. And one of the things that we're working on, and it's got to be done in an experimental way and sort of followed up and safely, is trying to develop stents that can remodel the portions of the aorta we can't see when we're fixing the type A, so that Dr. Ohman can then go in and not have to do a complex combination of open and closed surgery. He can put an endograft, and we've got a nice landing zone for that to treat further downstream disease. So I think those are the most important changes.
Great, thank you. Dr. Ohman, you mentioned, you said that about the endovascular repair not being for connective tissue disorder patients. There's so many questions about that. Can you explain why and what you worry about and why that's not what you do?
So even as I outlined in my talk, even in the best case scenario for patients who don't have a fragile aorta, we're not really seeing the great effect in terms of reduction of mortality, reduction of future events or surgery out until 5 years in a best case scenario. And what we're seeing really more is a lot of changes for the negative, either at the attachment site. Dr. Moon mentioned the landing zone, and that's really critical in terms of when you think about an endograft, you have to find a way to kind of tack it at one place, approximately one place distally. These devices are still relatively stiff, and so that outward force, even if you size it 1-to-1 or a millimeter larger than the aorta, you still have this chronic radial force in a weakened blood vessel that can induce a pseudoaneurysm or localized rupture at that site. We've seen that. That can induce tears in the dissection that change the true versus the false lumen perfusion and actually make things downstream in terms of the legs, the intestines, the kidneys, worse off than they were before. And so, as one of the larger centers in the world for treating patients with connective tissue disorders with stent grafts, yes, I think there's a role for it, but it's really, you have to be really thoughtful. So if the patient won't survive open cardiac surgery and we use it as a temporizing measure, yes, that should absolutely be done. If it's a patient who has a surgical graft for their, let's say they had an interposition for a type B dissection done open, and they've had the visceral segment replaced, and I just need to span to fix an aneurysm between the two surgical grafts, that is a reason, or that is an indication as well, because you're landing in non-threatened tissue. You're landing in dacron that Dr. Moon has sewn in. And so you're minimizing a lot of the risks. But once again, those patients aren't out of the woods, because we've still seen aortic events in that stented segment that looks great up to 8 years out. And so it really has to be judicious. I know it sounds very attractive and appealing that it's a much less invasive procedure, but it's fraught with complications that do require either bigger operation or in some cases an emergency operation after the stent graft has been put in.
Thank you for that. A lot of people asking. You're on mute if you want to add something, Dr. Moon.
I just wanted to say one thing, and that's what's important, to have a aortic team that works on these issues so that it's not one or the other, but we work together to sort of determine what's the best for that individual patient.
Great, thank you. Are there different recommendations for surgery if a patient has loeys-dietz compared to Marfan?
Well, I think, I forgot what year it was, but 15 years ago, so maybe loeys-dietz was sort of not even on the horizon. And Dr. Braven was very critical in bringing that to light, that is actually a little bit more aggressive disease process than, or syndromic process than Marfan syndrome, in that patients with loeys-dietz can have abnormal arteries in places that Marfan patients don't usually have. And also they can have tears and ruptures and things like that at a much smaller size. Dr. Braverman, maybe you can comment on that, because we're much more aggressive, I think, in a loeys-dietz patient prophylactically than a patient with Marfan, although we're aggressive in both.
Dr. Moon's right. And it's an important question. Loeys-dietz, of course, now has 5 types, and we're learning more, as Dr. Ohman said, about how the genetics predict the outcomes and how we are going to be making surgical and vascular surgical decisions based on what the genotype is. But in general, for loeys-dietz type 1 and 2 or TGFBR 1 and 2, prophylactic surgery at a much smaller size than Marfan syndrome is recommended. For some of the newer varieties, we just don't have as much information. And even amongst the ones we know about, we're learning more that some genes behave even more aggressively than others in the same family. So a lot of work is being done here, and it does take a multidisciplinary approach with a lot of shared decision-making about what's right for you. And your family history is very important. When someone in the family has an aortic dissection, we think about you much differently. We're much more aggressive about doing earlier surgery, and that's borne out in most type of aortic disease.
Great, thank you. I have a few questions about pairs procedure, which we didn't talk about. So Alan, come back. I see you want to answer one of these. But is there anything new on the pairs procedure? We did have a talk about it last summer at our international meeting. Is there new data? Is it being done in the US? Will it be done in the US?
Well, the pairs procedure could be performed anywhere. It's for those of you who don't know what it is, it's personalized external, what does it mean? Aortic root support, right? It's essentially wrapping the aorta. And the idea is you're trying to squish it and prevent it from expanding. Now, that's good for sort of preventing aneurysms that will rupture because it won't grow. But in theory, that will not prevent a dissection because a dissection occurs in the wall of the aorta. So if the wall of the aorta is weakened, necessarily that may not work. And sure, it can be done, and it's generally done in very, very small aortas that generally we wouldn't operate on necessarily at the current recommendations. But it is something to be considered. And I'm going to give you a historic example. Albert Einstein had an aneurysm. He went in to get a gallbladder repaired, and they found an aneurysm of his aorta, and they wrapped it in cellophane, I think. Is that right, Wes?
Yes.
They wrapped it in cellophane, and 2 years later, it ruptured. So, the wrapping there is some merit to it, and certainly it can be done. But I think it's not our standard therapy to get rid of the diseased aorta. Alan, what do you think about?
I think it's an interesting concept. As Dr. Moon said, we don't actually have the exact pairs protocol that's done in Western Europe, predominantly England and others, where it was developed, where a three-dimensional mapping of your own aorta is done in a personalized, that's why it makes it personalized, surgery is done where the aorta is surrounded by this graft. And in that series, with very carefully selected subjects, they've had really very good outcomes in the short-term follow-up. And it's just not FDA approved in the United States right now. So it is currently not available. Even if Dr. Moon said, I want to do that for you, he would have to come up with a different way to do it. It's just not an FDA approved procedure right now for root replacement in Marfan and loeys-dietz. But it is being done very carefully. And as Dr. Moon said, generally the aorta is smaller, 4.5 centimeters or so, without a lot of aortic valve disease. And again, in the follow-up so far in those patients, they've actually done very well.
Along the same lines,
We're always looking for something less invasive, but equally effective. And that's what Dr. Ohman and I are just moving forward in that direction.
along the same lines, what about the sleeve? I know I'm in Florida, so a lot of people do have what they call the Florida sleeve. So can you comment on that as well?
Yeah, no, the Florida sleeve is essentially just a version of root replacement with specific techniques. And the surgeon who developed that in Gainesville, Tom Martin, was a good friend of mine. So it's just the way he does it, and it's just a description of the technique. So it's essentially a aortic root replacement with various minor maneuvers.
Okay, great, thank you.
Very effective.
Okay, good to hear. Good to hear. So I know you both do surgery on adults, correct? And so some people are asking about some of this information pertains to children as well. Obviously, in Marfan and loeys-dietz, there's teenagers who might need this. Can you comment on that at all?
Yes, we see a handful of patients every year with a much more aggressive or malignant aortopathy. There's been a handful of patients in their teenage years that have undergone significant thorax or chest and abdomen aortic replacement, even though they're not technically adults. I remember doing one when I was finishing training with Dr. Moon and one of my other partners. And so they still require close follow-up with the pediatric cardiologist, and Dr. Braverman can probably speak to that handoff between the pediatric and the adult cardiologist. But for the most part, a lot of the surgical triggers, criteria, techniques are roughly the same between the two. The grafts may be a little bit smaller. We may leave a little bit more redundancy in them to allow for future growth. But the overall themes of trying to get the patient through the operating room and out of the hospital with an eye towards the future, even if that future may be several decades longer, still applies.
Great. People want to know, I mean, they see obviously that it's better to have surgery prophylactically than emergently. Besides the size, which they wouldn't know themselves, are there any other signs that a dissection is going to happen?
Unfortunately, not. There's not really preemptive. You don't sort of have low-grade pain and then sort of develop symptomatology. I mean, it's rare. Sometimes that can occur, or it sheds a light on maybe this patient's at higher risk. But I think the most important thing is the family history. If if your parents or your uncle had a dissection at a very young age and your aorta is sort of borderline, that might be a situation where you'd want to consider an earlier treatment approach.
And on the other end, Dr. Ohman, you talked about long-term surveillance after the surgery. So how frequently, with what kind of imaging, what do you recommend for your patients?
In the very early period, post-operatively or after the event, whichever it may be, we typically get one scan at 1 month, and as long as that or when they leave the hospital, and then 1 month. And if that looks roughly stable, then we go to 6 months. And if that looks stable and the aorta is kind of proven that it's cooling down and it's not misbehaving and they're not having episodes of pain with exertion, we may stretch that out to a year. And one of the things we've started doing here, particularly with patients in their 20s and 30s, is if they can tolerate lying flat for an MRI of their aorta, an MR aortogram, that's where we go, because there's no radiation. It uses a different type of contrast. It doesn't stress the kidneys as much. And so the follow-up changes a little bit depending upon how stable the aorta is. Now, if they've had a large jump in size, we may say we're going to go to another month, or we are going to go to 3 months. There's no absolute criteria that we use, but to Dr. Moon's point, it's more than just imaging. It's the history of the patient and their family, as well as what they're exhibiting in between those points in time.
That's helpful. Thank you. Does the dissection ever heal so that surgery isn't necessary, or does it stabilize? Does it ever heal?
Well, we see patients with chronic dissections, patients that have survived a dissection. But again, if you look at that old graph of survival after an acute dissection, it's very rare without treatment. But there are patients that do survive a dissection. It's unusual. What do you think, Dr. Ohman?
Going back all the way to medical school in Houston, which also is a major aortic center, I've seen one patient with a type B dissection that we would consider completely healed with medical therapy. And that's really, I think, the exception that proves the rule, is that this is not a disease that reverses. This is a progressive disease with dilatation, and it's all about preventing those downstream events for as long as possible with medical therapy.
Yeah, it certainly can stabilize, though, with good medical therapy. We have patients we followed for 20 years whose type B dissections have not grown over time.
That's great. Do you want to add anything to that, Alan?
The only thing I would add is that the variant known as intramural hematoma, where there's bleeding in the wall, about half the cases it does stabilize, and just like a hematoma or a bruise anywhere else, it does resorb. But those in connective tissue conditions are still fraught with concern. But that's one that can heal, or the false lumen can thrombose, so it does seem to stabilize and may not progress as much if there's a big contained opening there. But it usually is a lifelong illness.
Right. We're getting to the top of the hour. So before we close it up here, I just want to ask each of you, how do you feel about the state of aortic surgery right now? And what are you looking forward to in the future? And what do patients have to look forward to?
Well, I'll start. I'm excited by it. I mean, when I first got into aortic surgery, we had to replace, if we wanted to do something preventative, we had to replace the whole aortic root. We had to replace the valve, usually with a mechanical valve. Patients would have to take warfarin the rest of their life. And that's just, there's some annoyances to that. But now we can actually preventatively do surgery without forcing the patient to take warfarin, and that is a big change. The other big change is what Dr. Ohman is going to talk about, and that's us being able to treat the downstream complications of dissection without having to open the chest. Opening the left chest to fix the descending aorta in a type B dissection that's acute is very, very morbid and very mortal. So I'm looking for him and his team to develop further approaches to that regard.
Yeah, I will echo that. The whole reason I became a vascular surgeon was I was a third year medical student, and Dr. Hazem Safi in Houston looked me in the eye and said, "We're going to fix this type 2 thoracoabdominal aneurysm minimally invasively," and then proceeded to make an incision from the scapula and the shoulder all the way to the belly button. And my arc of my career will hopefully be reducing the need for patients to undergo that extensive of an operation with evolving technology. We're not there yet for patients without genetic triggered aortopathies. I'd love to say by my end of my career, we will be there to where we can offer better, less aggressively expansile grafts, or maybe grafts that do expand to more mimic the normal aorta. But I think the technology is really going to be changing and driving aortic surgery. But as Dr. Moon said, everyone wants minimally invasive, but it has to be equally effective, if not better, for the patients over the long run. And that's really, I think, going to be the challenge and kind of the arc of my career, like I said.
That's really very exciting. Thank you both so much. I'm going to share my screen for a couple of final slides here. Thank you all for your questions. They were great. If your questions were not answered, or if you think of other questions, Jan Lynch, who is the nurse in our help center, she can answer your questions. If she can answer them herself, she will reach out to our doctors here. And that's at marfan.org/ask. I should point out, and Helene put this link in the chat box, we've had several talks on surgeries in the past year. We had a surgery series in February, so you can go back and see the recordings where different doctors from high volume centers talked about arch surgery and thoracoabdominal repair, the complicated surgery that Dr. Ohman just talked about, root repair, even a talk on mitral valve repair. So we have all those, and there's one from last year on pair surgery. So plenty of resources for you all, and we'll send those links out also in the follow-up email. A few things that you should all know about coming up. Well, the GenTAC Alliance, which is presenting this webinar, we have a website with a lot of patient resources. So some general information about Marfan, loeys-dietz, but also bicuspid aortic valve and other genetically triggered aortic disease conditions. There's a lot of COVID information. Some people did submit some COVID questions, and the Marfan Foundation has specific information for people with connective tissue conditions who want to know about vaccine, et cetera. New video coming out tomorrow. Coming up is loeys-dietz Awareness Month. And as I mentioned before we started the recording here, the Marfan Foundation has its virtual annual conference coming up online. So no matter where you are in the world, you can listen to great information, connect with people. We have a lot of new topics this year. I know there's a lot of international people on, and I want to just remind everybody the international patient meeting will be in Paris next spring. Can't think of a better place to be, Paris in the spring. So we're excited about that. And I should also say the virtual annual conference will have sessions in different languages, specifically on aortic surgery, Italian, Spanish, French, and I believe German as well, and English. So we are here for you, and we do hope that if you have more questions or suggestions for future webinar topics, that you let us know, and we will try to help you out. So thank you, Dr. Ohman, Dr. Moon, for being here, especially Dr. Moon for stepping into pinch hit at the last minute. And it's a great session, and thank you both. Can't wait to get back to St. Louis.
Thank you, everyone. We look forward to having you, Eileen.
All right. Have a great night.
Bye now.